and you're in pain, soothing as a springtime rain, to have a friend right in your corner, your heart will feel a little warmer. Tender loving care, tender loving care, each warm and friendly touch lets someone know you care so much. Tender loving care, tender loving care.
Good afternoon. I'm Dr. Greenbrier Almond, and thank you for joining us on our program, Tender Loving Care. Over the past 38 years, we've been talking about this interface between Christianity and medicine, and today we'll continue a dialogue that we've been talking about throughout 2016 from time to time, and that's confronting the crisis of the opioid addiction. But I want to begin, since I want to always have that interface between Christianity and medicine, with the story from the Bible, particularly in Mark, the 4th chapter, the 5th chapter, where Jesus is healing the man who's naked and out of his mind, and later is clothed and in his right mind, the man from Gadarene. And it's a story familiar to you. I want to lift up a few verses that would show that as we have a crisis with drug abuse now, with opioids, that people act very strange, out of control. Situation here in town recently, a man was found in the morning sleeping on someone else's porch. The police had to be called because who knows if the man's going to be combative or what's going to happen when he wakes up. But the family discovered him, and so he was not in his right mind, and the situation worked out because the police were involved, and no incident beyond that. But we have, this is the crisis we're into, where I even myself, one day I was going to the post office early in the morning to mail something, and there's a person sleeping in the lobby in winter, and it's cold, and I'm glad they were indoors instead of outdoors. They would not have done that if they had not probably been on drugs or alcohol the night before. But over and over again we see those crises. So here's briefly the story from Jesus' time. His disciples were with him, and they had been teaching on the other side of the Lake of Galilee. And my wife and I had an occasion to go to Galilee a couple of Thanksgivings ago and see the setup. And they pointed out the Gadarene community across from the rest of the civilization of the town. It's sort of an isolated part, but they pointed out that from the hillside they believed this to be the exact place that Jesus healed this man. That is, there's only one place on the Lake of Galilee where there's a cliff and a bank that comes right down into the water. Other places it's flat, a marsh-like flatness around the lake, and you can see that it would not fit the profile, the geographic profile of this story. But in any event, Jesus is on the populated side of the lake, and he feels the urge, a calling, a sensing, God's direction to tell his disciples that they're going to. He's been teaching from a boat out, but there's such a crowd that they're going to stop the teaching. He's going to cross the lake, and so they do that. They go over across the lake. It points out here in Luke's story, because the 4 Gospels have overlapping stories, but even Jesus felt the urging to cross the lake because he didn't even stop to talk to his mother and his brothers who were there at the edge of the crowd, and they wanted to talk to him at that time. But he felt he had to go. So he went across the sea, and he discovered this tormented soul who lived in that city graveyard, the Gadarene area. And these were stone sepulchres there, and he was cutting himself on those, and he was crying out, and he had wails that scared people. He night and day, he'd be calling out, and so literally out of control. So Jesus approached him and, of course, healed him. And then he pointed out that in some cases, in this case, his disciples asked, well, how do we heal this man? And he said, well, through fasting and prayer. So there's degrees of healing that you can learn from this. But in any event, the unclean spirit that is in the man, they call themselves Legion. There's many of them apparently. They asked to go into pigs, and pigs are verboten for the Jewish people. They don't have pork in their diet, and these sheep or these pigs were being raised illegally. But anyway, the spirits asked to go into the pigs, and they may have a strategy about that because unclean spirits can be clever in themselves. But in any event, Jesus orders them into those pigs. Pigs run down and drowned in the sea. And the man is now able to explain himself. They clothe him. He listens to Jesus, and he's very grateful. It's a story of healing from what is hard to understand. It's not something we understand in modern terminology as you might say a leprosy, which we now recognize as an organism that grows and can be treated with a sulfa drug, or it's not the same as dropsy or congestive heart failure or other diseases that we now figure out the mechanism. We don't know exactly what the unclean spirit is, but the closest thing, and I think why it applies today, is that we are confronted with this epidemic of opioid addiction, and with that we have more suicides than we've ever had in America. On this program, I've talked in the past, I'm not going to go over all that today, but more suicides in West Virginia, for example, than from car wrecks, and more suicides in Upshur County than I've ever seen in my career. My son was in this summer, and he was describing not all the people from his graduating class living in Upshur County, but he was describing his class now 20 years out of high school, having identified, just as they met, 4 class members who have committed suicide. And there could be others, because these are always underreported. A phenomenal thing, because I can go back 50 years. I had a 50-year reunion this summer, and as far as I know, we have had no suicides in our class. But just to say, an unclean spirit, how do you want to characterize it? But something perverse and strange and that needs addressed is happening to our society, and part of it is the opioid addiction and all the things that go with that. Let me segue into a letter which has been written by Stephen J. Stack, who's a doctor, emergency room doctor, who is now the current president of the American Medical Association. This is an association of doctors that I've belonged to over the years. It's probably the largest and oldest medical society out there, except for the Psychiatric Association, which is older, going back to colonial times. But in any event, it's a very large medical group, and the doctors come together to wrestle with societal problems. And Dr. Stack has written a letter to all doctors who belong to the AMA, and he's asking all of us to confront this crisis, this epidemic. And of course, he sees it over the past 20 years as a major emerging public health problem. He sees it from the perspective of the emergency room where he practices. And he's reporting that there's perhaps 2 million people in America right now across all sorts of economic specters, small town, large city, poor person, professional person, poorly educated, well-educated, so forth, all across all spectrums, people dying every year, thousands dying every year from results of this opioid use, opioid abuse syndrome. and it's completely out of hand. In fact, it meets the criteria for what we call epidemic, which is the highest level of disease that we might have. If you look at different ways that this can be characterized, it's probably even more so than diabetes, more so than heart disease, more so than many other diseases, which cancer, many diseases that we commonly think of as being increasing in proportion and also epidemic. What he wants to say to the doctors, Dr. Stack, in his role as an ER doctor and as president of this large medical association, he says we need to begin to reverse the opioid epidemic, the overdose and the death that goes with this. And he said we need to begin to address it with non-pharmacotherapy methods. Now this is where it crosses, say, back into my familiar ground as a psychiatrist, because we don't treat our patients always with drugs, or we treat them with therapy, group therapies, 12-step approach. Various things can be offered for the person who's addicted. And most of the programs, if you understand the 12-step approach, are spiritual in nature. So it's not out of the question that we could be helping people with unclean spirits, to use a Bible term. So we need to be considering these approaches. Ironically, and I'm just trying to highlight what I see happening right here in Upshur County and in West Virginia, ironically, one of our major mental hospitals in Charleston is up on the block to be sold. And they in part explained in the newspaper article, Highland Hospital, that they have spent some $28 million on improvements to their building and to upgrade their services and so forth. And now the Medicaid program, as outlined by the state of West Virginia, and most of the funding comes from the federal government, is saying they cannot treat people with drug addiction in their facility. This is from 16 to 64. In a major age group where these things happen, and so they, having found that they have invested in something new and up to date and so forth, they can't pay for it. Now they're going to be sold and have another entity that I guess feels that they will be able to attract people who can pay to come, but it will probably not be West Virginians, and it won't help address our problem. But the first step, Dr. Stack is saying in dealing with this crisis, is to the doctors, get your patient who has an addiction problem, who's overdosed already, maybe overdosed 15 times already, has people who are increasing their dosage of medicines, calling for refills early, all the warning signs that they're getting into trouble. Get those people into a non-pharmacotherapy program. That's going to be hard in West Virginia if we don't have a program that matches their needs. Second point that Dr. Stack is saying is that there's, when you do prescribe opioids, and we're talking about OxyContin, we're talking about methadone, we're talking about morphine, codeine, medicines like this. If you have prescriptions for this, and it's useful for the acute pain syndrome, then give the minimum amount that you can for as short a time as you can. Doctors have gone the other way in the past 20 years. There's been what we call the fifth vital sign, the vital besides blood pressure and respiration and heartbeat and temperature and so forth. We want to monitor pain, and so doctors have increased their prescribing to treat pain. But if you treat the pain, relieve suffering, do it in a minimal way, the doctor is saying. And he's right, of course, because if someone has been on a pain medicine for 60 days, statistics right here in West Virginia say that they're going to be on that pain medicine for 4 years. So there's some very crossover point, easy to determine, not maybe as a patient and a doctor go through the process, but certainly afterwards, looking back, where the doctor has prescribed a little too long, a little too high a dose. The patients wanted it, they've asked for it, cajoled, threatened, so forth, and they got the medicine, but now they're on it not for 30 days, not for 2 weeks, but maybe 60 days, and then not 60 days, but 4 years. And so this is part of the tragedy. Almost, again, an unclean spirit, because a doctor would not normally do any harm. They don't want to do harm. We have our own pledge in medicine where we say, first, do no harm. And yet we've fallen into some type of trap in the last 20 years where we increasingly have used more opioids. Another thing that is suggested, and I've retired from practice in February 2 years ago now, a year and a half ago, I retired from practice. So I don't write prescriptions, I don't see patients anymore, but 43 years and out was pretty good, and I enjoyed the run. But at that time, I was a part of our prescription drug monitoring program, which Dr. Stack says we all should be part of. What this means is that if a patient has a prescription written and then it's paid for, there's flaws in the program, but if it's paid for and it's from a licensed pharmacy in West Virginia, then there's a record of this recorded with the state of West Virginia, and that prescription, if I dial up and I say what medicines in a controlled substance nature are my patients on from any place, any other doctor, any other pharmacy, then I can get a listing of those, and then I will know if my patient's doctor shopping, if they've been to very many ERs. Are they taking more than one pain medicine? Are they telling me the truth if I'm their doctor about what they're taking? And I can get a record of that. And then I can confront the patient and say, well, I'm your fifth doctor and I'm not going to prescribe today. Or whatever I choose to do if I'm treating. I can go through this prescription drug monitoring program and get information my patient may or may not want to tell me about. And so all doctors are asked to register for that and be involved in that. Of course, that takes considerable time going online, and we end up having to hire an associate or someone at least will help us out to get that type of data for us as we see patients faster and faster. Many doctors seeing patients about every 15 minutes, so you can imagine it takes a while to get online and get information. But it's possible, and it's necessary to do this. We want to reduce the stigma to enable effective and compassionate care. Dr. Stack says. There is a stigma, of course, to how drug addiction is presented or how use of opioids is presented. The stigma has been less and less because there's emphasis has been on treating pain. I've talked to classmates of mine who perhaps started off on a pain medicine because of cancer. Their cancer pain is less. They had corrective surgery. Everything's fine. Now they're taking their pain medicine to help them sleep at night. I mean, this is an off-the-label record, maybe a small amount, but it's not the right criteria for taking a pain medicine. I mean, a doctor needs to gently, and without stigma of accusing a person of doing wrong, to help them reduce their opioid exposure. Another thing is to identify and assist patients with opioid use disorder in obtaining evidence-based treatment. I've mentioned to that we need more programs like that in West Virginia. Actually, prisoners sometimes have a better chance of getting care than someone out here in the middle of West Virginia getting into a treatment program. If they're in prison and they've been in prison because of the other thing happening is minor robberies and anything to get their $100 a day habit or addiction cared for, they end up getting arrested eventually. They get into jail. They at least get some treatment program in jail. But a person out here in the community yet is stressed, just as distressed, but not able to pay for it, not able to get access to a program. We need more treatment programs out there. And finally, another thing is co-prescribed naloxone. There's been a move, and you probably have followed this all summer, that naloxone may be available in the future free, and certainly even without prescription, if not free, so that if you have a family member who is abusing drugs, may overdose, may die because they stop breathing, they can have a medicine called naloxone. Emergency services will carry it. They can inject it to the patient who's comatose when they arrive at the house, and the person starts to breathe again. Then they realize it's a drug overdose, opioid overdose thing. They now have given them least respiration for 15 minutes while they get them to the ER, where they can then continue that type of injection and other treatments until the drug effect wears off. Part of the overdose is that without naloxone, people die at home, and they cannot be helped. There's even a Good Samaritan law. West Virginia may still be debating that. I'm not sure that it's taken place, if it's been voted in yet. But in any event, if this were a college community, as it is here in Buchanan, and there's a college kid who goes to parties like college kids do, and he were carrying naloxone as a precaution, and he sees that one of his friends is in distress, he can then safely inject that into his friend, save the life, and then not be confronted with doing something criminal. The police will be happy, the EMS will be happy, and rather than abandon a friend who's comatose and flee the facility because it'll be too complex on that person, there's an attempt to have a Good Samaritan rule. Again, the Bible story of the Good Samaritan who is coming down the Jericho Road and is from another country, not involved with this Jewish person who's been set upon by robbers, is wounded and bleeding and in a ditch, and the Good Samaritan stops and helps the person and takes them to an inn and then pays for their care there, and then says, I will return, and if there's more care, I'll pay for that. So really going the second mile, all the teachings that Jesus would advocate, and now we use the term Good Samaritan in laws like this where naloxone's involved, and it's now called the Good Samaritan Law, where it's been enacted here in our society. So there's several things Dr. Stack has said, and I want to keep going in this frame, but I want to shift for your information to what doctors do tell our patients, what I told my patients when I was in practice, and what we generally say. And then you can go. I'll give you some sites. You can go online in terms of tender loving care if you have a family member involved, or you need to have information like this. You can go online and weigh some risk about how to help people, how to help yourself, perhaps in some cases. The information I'm getting now, I'm shifting gears a little bit, is from the American Family Physician. Way above and beyond all other specialties of medicine, family doctors write more opioids prescriptions than any other specialty. It's a very large specialty for one thing, and of course in primary care, people are coming with their aches, their pains, their injuries, and their surgical cases, and they're likely to get their care post-op after surgery from a family doctor. And so these are the doctors who write for the pain medicines. And so this is a good article, Weighing the Risk and Benefits of Chronic Opioid Therapy. This is an article from June 15, the magazine that comes out about every 2 weeks for family doctors, June 15 of this year, the American Family Physician. Several things I want to talk about here, but in this segment of our program, and this is a dialogue that I think we can continue talking more about what we can do. Think of Jesus as the great physician again. Think of dealing with someone with an unclean spirit, some unknown disease. Think opioid addiction right now, but remember, someone acting strange may or may not be on drugs. They may have other conditions. They may have other mental conditions. They may have an unclean spirit in the most biblical sense. But we have so many people like this among us now. So how are you going to talk? How would a doctor talk to his patient? If you're the patient or family member coming to a doctor, what can you expect the doctor to say as you begin to talk about your concerns about this patient who is acting completely strange and out of control and appears to maybe be on a opioid? Well, first of all, why do people die of this? I mentioned suicide. That appears to be, you can tell that by the notes that people leave. You can maybe tell it by the distress that they've had. They've talked of death to their friends before they did whatever they did to kill themselves, take an overdose maybe, shoot themselves, whatever they did to end their life. They get to the end of the rope. They're very desperate. But certainly one of the things that everyone has to be concerned about is a cardiovascular event. Heart disease is still a leading killer in our country, and as people get a little older, and there are a lot of people in the geriatric age taking these pain medicines, cardiovascular events take place. We think of those as starting after age 40, maybe the first peak at age 48, the second peak at age 58, when you think of death from cardiovascular events as a doctor. What are the drugs doing, though, if we was talk about that? First of all, there's an irregular heart rhythm, and so people can sense that. They can take a pulse and they can see that the rhythm of the heart is not normal. There's also sometimes, of course, the heart stops beating, and that will lead to sudden death. Another thing, and I watch the news in this season. We have the presidential election coming up. It seems to me there's news items I want to follow. So when I turn on, say, the CBS News, which I enjoy, CBS News, I'm not saying it's the most authoritative, but it's the one that I can turn to about 6:30 in the evening and catch a little bit of news. And in any event, I see that it's brought to me by medicines that treat constipation. And why would they be advertising that on the news? I mean, it might be diarrhea, it might be asthma, it might be new cars or potato chips or something else that they could be advertising. But they're advertising on the program for constipation. Well, it's because so many people have been taking opioids. It's an epidemic, remember. And one of those major side effects is constipation and abdominal pain. This can be quite severe. Even if the original pain, for example, would be a shoulder pain from an injury, then if the person's on an opioid, they may develop a lot of abdominal pain. And so people even think they need surgery. They may go to a doctor, and that would be something that might be considered. I remember one time in my past, when I was very young, I was not on any medicines, but I was running every day, and I enjoyed that until just recently. When I was 55, I had a truck accident, and I could not run, but I keep walking, and I'm grateful to God for that. But in any event, I apparently got dehydrated sometime in my late 20s, and I got a kidney stone, and I was passing that kidney stone. I went to the ER, and I was ready to have them operate on me because it was so severe. Fortunately, they plugged in an IV. I got hydrated. The kidney stone passed. I didn't even need any pain medicine. Everything was fine. But the abdominal pain that people get with their opioid addiction can be quite severe. And when I see that in a patient, I understand how they're suffering. I want to talk about one other aspect of this, then I'll have to ask you to join me on a future program, because there's a lot more we can talk about. Common everyday things that we all need to do to deal with this epidemic of opioid addiction, opioid use, misuse, as it happens in our society. The final thing I want to talk about today would be depression, because a lot of things in life are depressing. Maybe people actually have pain or increased reference of pain, like a headache. Someone says, you're a headache to me, or they say, you make me sick, like nausea, vomiting, or you're a pain in the neck. We use common expressions like that when there's interpersonal conflict, but people are starting to feel the distress of their job or their family relations, and they may be on the pain medicine to boot. And so there's depression can be a big part of this. A caution here, because of suicide and depression also go together, and so a doctor will be very careful not to prescribe something that can also be suicided. We used to have more suicides on Elavil probably than any other drug, and that was a medicine we hardly use at all anymore, but it was a treatment of depression. And when people took too much of it, more than a 2-week supply, they may, same thing we're talking about with opioids, they may stop breathing or have an irregular heart and die. And so depression can be a big deal because of chronic illness, because of life stresses, because it is a disease in itself. And so that has to be sorted out when people, family members come and start talking about opioids, or a doctor talks about prescribing opioids, because opioids will also lead to depression. A chronic use, say a person took an opioid for 4 years, they may end up with a lot of unintended consequences, one of them being depression. Well, there's a lot more to talk about. I'd like to continue this discussion. I hope you stay tuned. Channel 3 has always been good to sometimes run some of these programs back to back or rerun them in the future. So if you missed the first segment, listen to the second program. Or if you pay attention to Channel 3, our local community access channel, from time to time they'll announce how you can go online and actually view these programs again. And all those things are available through the technology right here in Upshur County. I'm very grateful for this opportunity to come your way, talk about something that is an epidemic. Until the next time, this is Dr. Greenbrier-Allman thanking you for joining us on our program, Tender Loving Care. Special thanks to Channel 3 for this opportunity to come your way each week. See you then.
Stories of a West Virginia Doctor, written by Dr. Harold D. Allman. A collection of 55 short stories about his experience as a small-town doctor in central West Virginia. And Tender Loving Care, Stories from a West Virginia Doctor, Volume 2, written by Dr. Greenbrier-Allman, using videotapes to write 70 additional stories of his father's very colorful life as a small-town doctor. They can be found for purchase at Amazon.com and most local bookstores. Tune into Channel 3 Buckhannon for Tender Loving Care with Dr. Greenbrier-Allman, where he talks about the connection between Christianity and medicine.